Thank you so much for being here tonight. Welcome. Thank you for joining Sharsheret this evening to discuss a topic that you might not expect a women's cancer organization to address, men's health. In the past several years, Sharsheret has worked to ensure that men's health, especially as it relates to hereditary cancers, becomes a priority. Tonight is our 4th annual Men's Health webinar. So let's begin by answering that question. The most common question we received, in fact, in advance of tonight's webinar: why would Sharsheret be hosting a webinar on men's health? So let's go there. We know that many of the genetic mutations that increase diagnostic risk of breast cancer and ovarian cancer increase the risk of other cancers as well. We're going to be talking about that tonight. We also know that men and women pass these mutations down in equal numbers and pass them down to both sons and daughters in equal numbers. And so therefore, we know that this is not just a woman's issue. This is not just a men's issue. This is a family issue. This is a community issue. So once again, thank you for joining us tonight to be a part of this important conversation. Tonight, we're going to focus specifically on risk-reducing opportunities across the spectrum, from genetic testing to cancer screening to lifestyle behaviors, for men who are at known heightened risk, as well as for men without a known mutation. But before we begin, I have a few housekeeping items to share. If you would like to remain private, you have the option to turn off your video and rename yourself, or you can call into the webinar. Instructions are in the chat box now with both options. We also now have closed captioning available. To display live captions, on the bottom bar, click Captions and then Show Captions. You may have noticed you were muted upon entering tonight's Zoom. Please stay muted during the call. If you have any questions, please feel free to send them to the chat. We will do our best to answer them throughout the program. Excuse me for one second. To get rid of the reverb. I want to start by thanking our sponsors for this program, whose generosity allows us to continue to provide support and education to you. AstraZeneca, the Basser Center for BRCA, Daiichi Sankyo, GSK, the Max and Anna Barron, Ben and Sarah Barron, and Milton Barron Endowment Fund of the Jewish Community Foundation of Los Angeles, and the Sigmund and Edith Blumenthal Memorial Fund. As a reminder, this webinar is being recorded and will be posted on Sharsheret's website alongside the transcript. As always, participants' faces and names will not be in the recording. Okay, so tonight's format will be a bit different than our usual one. Each of our presenters will provide a very brief overview of their area of expertise, and then we'll devote much of the evening to Q&A. We received a great number of excellent questions before today's program through the registration process. If during the program you have a question that would benefit all the participants, please enter it into the chat box, and we will do our best to add that to the Q&A that will be the majority of this program. As a reminder, Sharsheret has been providing telehealth services to those impacted by breast cancer, ovarian cancer, and those concerned about their risk for over 20 years. As we move into tonight's webinar, I want to remind you that Sharsheret is a national not-for-profit cancer support and education organization and does not provide any medical advice or perform any medical procedures. So the information provided by Sharsheret and tonight's speakers is not a substitute for medical advice or treatment for a specific medical condition. You should not use this information to diagnose or treat a health problem. As always, seek the advice of your physician or a qualified health provider with any questions you might have regarding a medical condition. So, stories are important to us at Charsheret. They inform our work, they inspire us, they make it easier to understand complicated information. And tonight, we have an important video featuring Don Kreef. And tonight we actually have Don Kreef with us. So we are going to share that video and then invite him onto the screen.
The whole journey started with my mother in 1986. She was diagnosed with ovarian cancer, which was a complete shock to everybody. It was very scary. And then my uncle and my grandfather both had breast cancer, which is very unusual. At that point, nobody had discussed hereditary cancer. Nobody was aware of the BRCA gene or that it potentially can impact your entire family. Eventually, my mother got tested, found that she was BRCA2 mutation positive. And then my uncle tested positive, and then my sister tested positive as well. So I just figured I was next in line. So I am a neurosurgeon, and because I understand the health side of it, I thought I had a real responsibility to get tested. But being a typical male, I, pushed. Honestly, maybe I didn't really want to know the answer right away. But once I actually got tested in 2016, I found that I was BRCA2 positive. And I said, I need a breast surgeon. And I said, I want to get a mastectomy. As a male, I think they thought it was a bit unusual, no question. But the fact that I'm in the medical field and, basically everything in life and in surgery is all risk versus benefit. So knowing that my uncle and my grandfather both had breast cancer, it was like essentially, a no-brainer. There's no question that I was going to do it. Male breast cancer is a very tough problem. A lot of men don't even think it's possible to even get this. They think it's a female disease, so a lot of men die from it because they wait forever and ever for it to be diagnosed. So I want people to understand that if you have a family history of breast cancer, you need to be tested, period. Because with BRCA, it's not just you that's affected. It affects generation after generation after generation. And if you have a daughter that potentially could get ovarian cancer or a son that could spread it to his children, you have a real responsibility to do it. And I think it's important that that word is spread.
Wow. I am going to spotlight you in a second, but I want to say first, just that was incredible. Don is a clinical assistant professor in the Department of Neurosurgery at NYU Grossman School of Medicine and the chief of neurosurgery service at Long Island Community Hospital. As you heard, he is also someone at high risk for cancer, but I'm going to let him tell you more about that.
Thank you very much. I am proud and happy to be part of this. I realize I only have 5 minutes. I forgot about that video, so that kind of told the story for the most part anyway. But like the video said, I mean, I think that I have a unique perspective in terms of being a healthcare provider as well as being a provider and part of the whole BRCA family. And the BRCA gene has been part of our family really since 1986 when my mom was diagnosed. And she was diagnosed with ovarian cancer. Thank goodness she's been through hell, but she's still alive all these years later and doing fine. But the fact that so my mom was initially the one that started this all, and in basically in the early 90s she became part of the first study on BRCA through the NIH. My sister was then tested. She's positive, as well as her daughter. She has 2 sons. One's tested, has been negative, and the other is not been tested yet. My mother's brother who's my uncle in California, had breast cancer, and their father had breast cancer. So, clearly it all started back with my grandfather. And, knowing that this has all gone on in my family for a long time, I knew I needed to be tested, but, typical male behavior, I was involved in, working and residency and, not really thinking much about the BRCA stuff, as it affected me. I didn't get tested all the way till 2016. So, knowing in our family, this has been part of our family since the mid 80s, and not being tested for a long time wasn't the best idea. But the bottom line is I finally did it. And I initially was going to be tested probably in like 2010 or 12. And I remember they're like, I was going to do it at the hospital I worked at. And they said, you have to go through genetic counseling. And I was like, all right, I'll do it. I made the appointment for genetic counseling and then never went, postponed it, and kept on postponing it until 2016. And I actually was with one of my friends who's a breast surgeon in the OR, like holding room before surgery. And I'm like, hey, I got to get tested for BRCA. Can you do it? Went to her office and got tested. And, in May of 2016, results came back that I was positive. And at that point, there was basically no discussion. Like, I went to see another one of the breast surgeons that I knew that worked there. And she's like, hey, what are you doing here? And I said, I want to get a mastectomy. She's like, what? And I said, she had done, she's previously done mastectomies on men, but not as survivors, BRCA positive with, negative, imaging or negative breast cancer studies at that point. But the way I felt about it is like, I knew what the risk was, and the risk, in men is a lot lower than in women. But knowing that there were two adult males in my family that both had breast cancer, I knew that my risk was probably higher than most people. And, knowing the kind of surgery that I do versus, what a simple mastectomy is, for a man, it was not even a question about it. And I set it up to be done in November, had it done in November of 2016. And I remember deciding specifically that, I'm lucky because I found out about this before I developed any kind of cancer, and decided that I was going to share my story, and did it all through Facebook. And I was on the news at one point, for all the stuff. And, all the way 8 years later, I'm still, advocating and trying to help people and spread the word around. So that's been going on, essentially since 2016. I have had no problems. And, luckily it's been fine. I have 2 children that have yet to be tested. And, we'll see how, that's obviously going to be a big deal. Because as Melissa said, this is something that, follows you through life and follows your generations through life. Once you're positive, until you're negative, until family members are negative, it's not over. So, I'm happy to be here and happy to answer any questions going forward.
Thank you so much for sharing your story. And we're going to bring you back when we do the Q&A, so you'll have the opportunity to answer questions. So if you have any questions, please put them in the chat box. Next, we have with us, and I'm going to spotlight her. Next, we have with us Peggy Cottrell. Peggy is a certified genetic counselor and Sharp-Sherritt's genetic program manager. She's a graduate of Sarah Lawrence College Master of Science in Genetic Counseling program. And at Sharp-Sherritt, Peggy consults with women and men and families and answers individuals' questions about their family histories, BRCA and other mutations, and personal risks for cancer and much more. So Peggy, welcome to the screen to give us a very quick overview of some of the genetics involved here. And I see your slides are coming up now.
Okay, great. So I think to start with, everything on this slide has already been mentioned, and that's that this is very much an issue, not just for women, but for men also. And it's important when you're looking at your family tree to look at both sides, see what's going on, and think about the men and the women in the family. Next slide. So I want to start by talking about the impact of BRCA1 and 2, which increases the risk for men to develop prostate cancer, pancreatic, melanoma, and male breast cancer. And we're talking when we, you know, Sharsheret is a Jewish organization, and we're talking about people with Ashkenazi ancestry. We very much talk to people with BRCA1 and 2 mutations, but we know that there are other hereditary mutations that can predispose to cancer, and the risks will vary depending on which gene is implicated. Next slide. So there are many genes, and these can lead to many cancers. And so part of it is knowing that for, let's say, breast cancer, there are many genes that could predispose to breast cancer. In the first picture, we see breast in the middle and a bunch of different genes that can predispose to that. We also know that each genetic change can lead to different kinds of cancer. And so it's very important when one is testing. Most testing nowadays is done with a broad panel that we look and at the family tree and see what kind of testing needs to be done based on what kind of cancers are there. Next slide. So I'm going to mention just a couple other genes that can have an impact on men. CHEK2 is a moderate risk gene. It increases the risk for breast cancer in men, prostate cancer in men as well. Now, we used to say colon cancer, but just in a recent update of the national guidelines this year, scientists are suggesting that the risk for colon cancer with CHEK2 is probably smaller than we thought. And so there may not be an increased risk for colon cancer with CHEK2. There's significant variability in families with CHEK2. And so it's important to look at family history. There's also a founder mutation in the Ashkenazi population that can be confusing. It's a little bit less of a risk than a typical CHEK2 mutation. And if you have questions, give us a call and we can explain in more detail. Next slide. So APC is another genetic change that causes a rare predisposition to hundreds to thousands of polyps and can also increase the risk for other GI cancers. But it turns out that there's a common risk allele that isn't exactly a mutation, but does significantly increase the risk for colon cancer, approximately double. And we see this mutation very commonly in about 6 to 10% of people with Ashkenazi ancestry. I talk about this a lot at Sharsheret because we have a lot of Jewish callers. This particular risk allele doesn't increase the risk for any other cancer except colon cancer, and makes that risk probably about 10 to 12%. Most people with this risk allele will not get colon cancer. Next slide. And then finally finishing up, Lynch syndrome is an inherited predisposition to a combination of colon, uterine, ovarian, and some other GI cancers. Lynch syndrome is more common in the general population than hereditary breast and ovarian cancer. So this is an important cancer to be aware of. Colon cancer is probably a little more common in men than it is in women. And unlike most other screening, colonoscopy not only screens for early diagnosis of cancer, but can actually prevent cancer by removing the precancerous polyps. And that, I believe, is the end. Next slide should be done. And happy to answer any questions about genetics once we get to the question and answer.
Thank you. Yes, we're going to bring you back too. So we've heard Don's story and we've talked a little bit about genetics. So what makes the most sense now is to have Dr. Stu Ackerman join us. I'm going to spotlight him. He is a board-certified gastroenterologist practicing in the Dallas-Fort Worth area of Texas. Aside from performing screening colonoscopies, Dr. Ackerman has been on the forefront of initiating preventative care for gastric and pancreatic cancers in at-risk patients. Thank you for joining us tonight.
Thank you so much for having me. And this is definitely a bit of a passion project for me to be able to get to a wider audience to talk about screening, because that's really where we make some of our biggest interventions. Can you please hit the next slide for me? So I'm gonna speak about common screenings for 3 cancers, and then we'll focus back on BRCA patients in particular. But first, let's talk about colon cancer screening. So the average risk patients who do not have a personal or a family history, and this is true for both men and women. The current guidelines recommend starting screening at the age of 45 and continuing at interval, depending on which method you choose to screen with, until age 75. And then it's a bit debatable, based on personal risk and findings throughout those 3 decades, on whether to continue on from 75 to 85. And in general, if someone is considered in good health, we usually continue until 85. Higher risk patients with either genetic abnormalities, family history of colon cancer, colon polyps, those patients should start earlier depending on the risk factors. We typically talk about, in general, starting at age 40 or 10 years younger than the age of the affected relative. When we talk about current screening options, we talk about colonoscopy, which is still considered the gold standard. As Peggy had mentioned, it not only allows you to screen for colon polyps, but it allows you to intervene and remove the polyps to prevent the potential cancer. There also, you may have seen stool-based testing. Cologuard would be an example of this. And this is basically where you would use a stool sample to check for certain DNA that would be found in the stool, or rather shouldn't be found in the stool. And usually we recommend repeating that every 3 years, because it's not quite as good at picking up cancers, and in particular, precancerous polyps. So if we shorten the interval, the idea is that if we miss it now, we'll catch it in 3 years. And then we also talk about stool FIT, or immunohistochemical testing, and that's usually more looking for DNA, blood, or combinations. You may have started to hear more about these blood-based assays. So essentially a blood test to look for either genes or other abnormalities that could give you an idea that there may be some cancer brewing. It's definitely an exciting part on the next frontier of colon cancer screening, but it's not quite ready just yet. The numbers at the moment are not good enough to make this a wide-based test of choice. And just to throw it out there, if you do choose an alternative to colonoscopy, the best test is the test that gets done. But if you do find an abnormality, you always want to follow that up with colonoscopy. You always want to answer the question of, well, why was the test positive? Next slide, please. Prostate cancer screening is a little bit more challenging. The guidelines have shifted several times, especially recently, and there is a little bit of discrepancy between different colleges and the U.S. Preventative Services Task Force into what the recommendations are. But to make more of a generalized recommendation, in general, we will recommend screening with a test called the PSA, or the prostate-specific antigen. This is a blood test. It by itself is not the best test, because what it's looking for is excess production of this prostate antigen, and any excess tissue will cause that to rise. And that could be because of a cancer that's growing, or it could be from a prostate that's becoming large and producing extra tissue. So any elevated PSA, sort of your first screen, prompts follow-up examination, typically with an MRI, and then based on that, you can decide, if there's a concern for something growing and whether or not a biopsy would be beneficial. The U.S. Preventative Services Task Force and the American Urological Association recommend considering screening between the ages of 55 and 70 in average risk men. So again, men who do not have a personal risk factor, such as close family relatives who have cancer or genetic abnormalities. The American Cancer Society is a little more aggressive and recommends starting at age 50. And it should be done repeated every 1 to 2 years, depending on which guideline you're looking at. And again, higher risk pertains to certain abnormal genetics, such as BRCA2 and a family history of prostate cancer. Next slide. Pancreatic cancer screening is a little more challenging, but this is something that is quite exciting because it is emerging as another way for us to decrease the overall pancreatic cancer risk. In general, we have a certain set of guidelines that we like, or check boxes that we like to hit in order to say that it makes sense to be screening for a certain cancer. It's not as simple as we have the technology, but it needs to affect enough people, it needs to be accessible, and there needs to be something that we can do about it. And certainly, it needs to be cost effective for a population. So in that vein, pancreatic cancer screening, although possible and available, doesn't necessarily make sense to do for everybody and is currently not recommended for average risk individuals because the incidence of pancreatic cancer, or the rate at which we see pancreatic cancer in the general population, is currently less than 2%. And as a comparison, breast cancer is about 5%. Colon cancer also is around 5% in the general population. So this is not, even though we hear about it more, possibly because it affects people we know, or it gets diagnosed at later stages and tends to have more difficult outcomes, it's actually not as common. So how do we figure out who should get screened? Who can benefit from this potential life-saving intervention? Well, we want to find the populations that will be affected at a higher than 5% rate. So people with multiple first-degree relatives that have pancreatic cancer, or certain genetic changes, or both. BRCA2 certainly being one of them, PALB2, as Peggy had mentioned, ATM, and this other gene called the STK11. And you would screen by performing a blood test called the CA19-9, and then cross-sectional imaging, something like a MRI, sometimes a CAT scan, or an endoscopic ultrasound. Next slide. Thank you. And this is my last slide. So specifically focusing on our BRCA1 and BRCA2 patients, and our BRCA1 and BRCA2 affected men. So in general, the breast cancer risk does seem to be higher for patients with a BRCA2 allele rather than a BRCA1. We do recommend annual breast exams and self-breast exams starting young, starting at age 35, because as a genetic cancer, it tends to affect younger patients. And we also recommend aggressive imaging. So because, as someone had mentioned in the questions on the side of the Zoom, that males don't have as much breast tissue, we don't recommend mammography. We won't get good imaging with that. So instead, we recommend an ultrasound alternating with MRI every 6 months. But that is a lot to ask. And patients can be offered prophylactic removal of the breast tissue, and are even recommended in some cases to do it, especially if they have gynecomastia or excess breast tissue, to remove it prophylactically to reduce that risk. Prostate cancer similarly has a much higher risk than compared to the general population, can be as high as almost eightfold increase in prostate cancer, and therefore we recommend uniformly that patients should get PSA, mostly starting at age 40, some select populations at 45, and on the more aggressive end by repeating PSAs annually. And we even, according to some guidelines, recommend in higher risk patients, multiple family members to incorporate imaging as well at certain intervals. And then lastly, pancreatic cancer risk. BRCA1 only has about a 2-fold increase, but BRCA2 has about a 5-fold increase in lifetime risk of pancreatic cancer. And therefore, we do recommend, especially if someone has a first-degree relative, that they enroll in a program which includes checking that blood test once a year and getting a baseline endoscopic ultrasound and possibly alternating with MRI annually. Melissa, you're muted.
Sorry about that. That was great information, and not something that everybody thinks about. Okay, so we've talked about genetics. We've talked about some screening protocols, but not everything that you can do to reduce your risk falls into those categories. So I am going to actually spotlight our next speaker right there. Okay. Finally, I want to welcome Lillian Rodich. She is a physician's assistant, a PA, on the integrative medicine team at Sloan Kettering Memorial Cancer Center. She has spent her entire career caring for patients with cancer, and her background is in nutrition, and she uses her expertise in this area to emphasize how diet, lifestyle, wellness can affect the health of patients with a history of cancer or patients receiving active therapy for cancer. She uses integrative medicine alongside conventional therapies. Thank you so much and welcome to the screen.
Thank you so much for having me. I'm in amazing company tonight. Thank you. So tonight we've heard so much already about the genetics that predispose us to certain conditions. And I'm here to talk a little bit about how lifestyle factors can sometimes offset some of those risks and minimize our overall cancer risk. Next. So as everybody has spoken about already, I'll go through this one very quickly. The genetic risks are there, right? And especially for these populations. The one I really want to highlight is the colorectal cancer risk. Colorectal cancer at this point is the highest rising rate of cancer, especially among young adults. And so it's a really unique area that we have to pay attention to. And if you already have a BRCA positive gene, your risk is even higher of this. So with this slide, what I really want to have come across is that lifestyle can still make a difference. Our genetic blueprint is definitely part of makes us who we are and does play a role in what diseases and what things will come up for us. But our lifestyle also plays a role in which genes will be turned on. And so this is where we have that empowerment to be able to do something about the genetics that we're given. Next. So I want to talk about the most impactful lifestyle factors. Before I go through the list, what I really want to get across is that there's not one single one of these that's more important than another, and there's not any one of them that trumps any of the rest. What's most important is the synergy of all of these so that they're working together and that lifestyle as a whole is improved. And so some of the ones that we will highlight is not smoking, having physical activity and exercising 150 minutes per week, an increase in vegetable intake. Most people are surprised to hear this number, that it's actually 5 servings of fruits and veggies per day that's recommended, cutting down or cutting out completely alcohol, and keeping a healthy weight. There are certain others that we sometimes will discuss, such as sleep, stress management, social interactions as well now seem to play a role. And again, what I really want to highlight here is that there's not one of these that I could pick to say this is the absolute most important one. It really is this synergistic formula. And so that if you have somebody who maybe is focusing on exercising so much that they are maybe not sleeping enough or getting really stressed out about meeting all of their numbers, that's also not great for health, right? Or if you have somebody who is, very fixated on diet and it's making their stress levels rise and they are maybe not keeping a healthy weight, maybe they're underweight because they might be overdoing it on diet, that's still not great for our health, right? And so you see how all of these factors need to be perfectly aligned in order to get the most benefit. Next. I just wanted to share some resources here so that you all have something to look back to after this presentation. A couple of the prevention websites here from my own hospital, Memorial Sloan Kettering, one particularly on colorectal cancer, and then a cancer.org prevention blueprint as far as diet and physical activity and exercise guidelines go.
Thank you so much. Oh,
and just one last slide.
Yeah.
What I really want to sort of end on is this idea of don't lose the forest through the trees. So I say this at every single one of my new visits, that really we need to be focusing on the foundations of health, on these principles, the diet, the sleep, the stress management, moving, not smoking, cutting down on alcohol, having mind-body practices in place. I think it's very easy to get overwhelmed by the information and misinformation out there. And so one thing that I have noticed on so many of my visits is that I'll have patients sort of going down rabbit holes, and understandably so. We all want something that we can do, right? But some of these rabbit holes lead us down really, aggressive types of maybe alternative methods that aren't as effective. Meanwhile, we don't have our sleep in a good place. We don't have our diet in a good place. And so really not losing sight of the big principles and of the big picture of health. Thank you so much.
Wonderful. Thank you. Thank you. So we really have a very comprehensive look. I am going to add some spotlights here. If you give me just 1 second, because we have a lot of questions. And there are a lot of good questions, and we're going to do our best to get through as many of them as possible. This was honestly just so much great information. Some questions are very clearly geared toward one or another of you, and others, a couple of you could answer. So let's just start and see how it goes. So one of the most meaningful questions I read today was, I'm not even really sure where to begin. Let's start with the question, how do I know which type of doctor to see? Maybe I have a little bit of cancer in my family history. I'm of Ashkenazi Jewish descent. I consider myself a fairly healthy person. What's the first thing I do? Dr. Ackerman, let's start with you. And then if anybody else wants to add, we can do that.
Sure. So sometimes with a strong family history, people actually go straight to a geneticist, sort of go to the source and, have them map out their family tree with them, get genetic testing and sort of discuss the ins and outs. But I mean, for someone who is not sure or maybe doesn't even have the strongest family history, best place to start is with your primary care doc, your OBGYN. And, you're not the only person, and they typically have a lot of experience with this. And nowadays, many, many, many physicians and mid-levels and the like all feel very comfortable utilizing some of the mainstream blood tests that we use to check the genetics.
Let me ask you a follow-up question. So for women, yes, it's an easy decision to just go to their OBGYN. But for men, it's not so clear. They might have a primary care physician, but there are lots of specialties that this sort of encompasses. And from what we hear, they may have to be very proactive at that appointment to have this conversation. What do you think?
It's certainly more challenging to sort of get male engagement. I can speak for myself. We deal in my practice with a lot of pancreatic cancer. I'm blessed. I work in an area in DFW where I work closely with several geneticists, several OBGYNs, several breast surgeons who are all very focused on proactive genetic counseling, education, and testing. And we have a network where patients get folded in. And when we diagnose any young patient with any of these cancers, if I diagnose a young patient with colon cancer, a young patient with gastric cancer, a young patient with pancreatic, my OBGYN and breast and gyn oncology colleagues, if they're getting patients with young breast, young ovarian, young endometrial cancers, part of the treatment plan is getting the genetics and then getting that education to explain this goes beyond you. It's not just in how well we treat you, because we need to know if you're at risk for other cancers that we're not thinking about, but how it affects, in the mushroom cloud of your family, right? How does it affect the family members that are on the same level, your siblings, your kids, their kids? Because at the end of the day, both positive and negative, right? If you find that you are diagnosed with a gene and everyone around you tests, well, the people who are negative, we know don't have elevated risk necessarily, don't need to be entered into these programs, and don't necessarily have to test their siblings or their line any further. But those that are positive, now can be much more proactive. And the rule in most cancers is that if you find it early, or even in some of these cases, find it before it even becomes a cancer, we don't talk about 5-year survival. We talk about survival. We talk about living your full life with expectations. So the idea is to try to find who we can pull into the fold. And sometimes it's a combination of speaking directly to the patient or their family members, or making yourself available so that if they don't have a primary care physician, and I'm in this position because many patients don't necessarily have primary cares when they come see me for colonoscopy, and I will tell them, have your brother, have your son get tested, but if they don't have someone, they're more than welcome to come make an appointment with me because I know the family history, and I would be happy to have them tested and guide them on where they need to go.
Perfect. Thank you. Okay.
Melissa, could I just add as well? So a lot of cancer centers, Memorial Sloan Kettering included, we do have high risk programs. Ours for breast cancer is called the RISE program. It stands for Risk Assessment, Imaging, Surveillance, and Education. And so many different cancer
Sorry about
centers,
that.
if you're not in the Northeast and don't have access to MSK, a lot of cancer centers will have these high risk programs. So you can always make an appointment with something like that to say, I have a family history. I'm not sure where to start.
I have something to add as well. I think also, like, where, Lillian works and where Stuart work are, and where I work too, are big centers, NYU, and a lot of the doctors, the primary care physicians out in the community are not that educated, surprisingly, about this kind of stuff too. So it's like, I've seen so many stories like of the male breast cancer, and I'm on a bunch of different, like, panels and things about this. And so many people go to their doctors, with a lump or with something that the men go, they don't even want to go. They can't get them to go. But if they go, a lot of times it's just like sort of poo-pooed by their primary care physician. Hey, come back in a year, come back, and it's no big deal. Don't worry about it. Men don't really get breast cancer. So it's important, when we're talking from, from places where this is a very common thing, but, the general population out in the rest of the world might not take it so seriously as we do.
Yes. Thank you for that. And thank you for your patience with our tech issues. We have a lot more questions. So let's talk for a second about people who are at general risk, people who don't have a strong family history or who don't have a known mutation. Other than like primary care visits, colonoscopies, and mold checks, what annual screenings are recommended for someone without a family history? Really quickly.
An annual dermatology visit for skin checks is completely underlooked and underutilized. For women, of course, your annual OBGYN visit as well. I would say those two come to, top of mind.
Okay. Lillian, as long as you're speaking, your presentation sort of ended a lot of questions that came in that were geared for you. What are, if you had to choose, the top 3 things and questions like that? So I'll give you one that came through that was a little less exactly like that, which is, I'm having trouble convincing my father, my brother, my partner to care for themselves. If I can only nag about one thing, and it's not just actually, I'm sure you all have things you'd like to say, but let me give you all that opportunity. If you can only nag your male loved one about one thing, what would it be?
It's a great question. I would say actually just changing the mindset around this, and rather than just trying to convince somebody of making a change, I would say lead by example and see if they follow, right? And so if you have somebody in your family who's maybe, not not the best cook and not interested in vegetables, but you lead by example by saying, I'm coming over and we're doing family dinner night, and you show the menu recipe and it's delicious. And you're like, guess what? This had multiple vegetables in it and it had no red meat and all of these things that are, in the sort of anti-cancer living kind of way. If you have somebody who is hesitant to go exercise, maybe you say, I started going on these daily walks and they've really helped me clear my mind and I have less pain and whatever. Do you want to go with me tomorrow? I'm going to come pick you up. We're going to go on this walk together. So not nagging, showing by example, doing the work and having them follow along.
That's great.
Get the whole family involved.
Peggy, Dr. Ackerman, do you have anything you want to add? Those were good. Those were good. Okay,
Yeah,
great.
I have one.
Those
I have
were
one
great.
thing. I have one thing to add. I mean, if
Okay, great.
the bottom line is, if you're BRCA positive and you're at risk, and you don't care about yourself, and you're a man, you got better figure it out, because if you don't realize you can give it to your children. And a lot of people don't understand that. It's
Right.
one thing if you're positive and you have 3 kids, 2 kids, 1 kid, it doesn't end until they're negative. So if you don't even care about your own health, which I hear a lot of times, why do I need to get tested? That's the reason you got to get tested.
Yeah, and I'll echo that as well, because similar concept. Sometimes that's the way to get to people, is just to explain. I completely respect if you don't necessarily want to know, or even if you know you're not going to do anything, but you have to think about the people around you who will benefit from knowing.
That's a great lead in. And I'm going to ask Peggy if she can take just a second to talk briefly about PGT and how that's an option if someone knows their mutation status early enough. Peggy, you're muted.
Yes. So it's an option if you have tested positive and you're planning to have children, to use IVF and testing of embryos to avoid passing the mutation to the next generation. Now, this is an expensive and difficult process, and it's not for everyone, but for some families, it's the right choice, and we can help people at Charshara, we can help people figure out resources for that.
Thank you. Thank you. Couple of similar questions. One is there any medicine that's available to men who are previvors, as the term you used, Don, who know they are at higher risk but have not been diagnosed? Sometimes with women, they're given something like tamoxifen. So is there an equivalent for men? And that's the first half of the question. So who would like to take that?
There's not. I think that's why I want to just highlight the lifestyle factors. That is our first line defense. That is the medication, right? Your prescription is 150 minutes of exercise a week, 7 hours of sleep, 5 vegetables and fruits a day, and trying to work on stress management, because those are the things. So like I said before, we have these risk factors in this genetic blueprint, but sometimes our lifestyle factors, they can amp this up and turn them on, or they can kind of keep them quiet, and then that risk is there, but it's not getting amplified. And so what you do in your daily life makes such a big difference in as far as what's going to happen with those genes.
Yeah, thank you. Thank you. So taking this a little bit of a different direction, somebody asked, are there any gaps in research specifically on men's cancers that the medical community is working to address?
So, I mean, I'll throw out there's research in general is an evolution, right? And we always learn new things. To Lillian's point about, for instance, BRCA and colon cancer risk, for years, we actually thought it was an even higher risk. And a large study came out several years ago that showed that there still could be an elevated risk for BRCA1 patients, but it's thankfully not quite as high as we thought. And genetics in itself is an evolutionary process, right? I think I did see a question along the side of how often should I update my testing, right? If I'm testing negative, should I be tested again? And the short answer to that, and I don't mean to step on anyone else's toes, so please jump in. If you've had testing a long time ago when where panels are much, much smaller, and especially if it's with a company that doesn't do active retesting, the answer might be you want to get retested. But some of the larger groups at the moment, the larger laboratories, will actually, you can opt in that they'll keep your sample. And as they highlight new genes and as they clarify VUS status, so VUS was mentioned before, and it's a variable of unknown significance. It means we know it's different, but we don't know if it's good or bad. And a lot of times, over the years with testing, we figure out by looking at the population that has it and outcomes and whether or not they develop cancers, whether or not it is significant or not. And they'll go back and they'll highlight all the patients that came up with that to let them know, hey, it turns out this VUS that you have that we weren't sure about is in fact something that you should be paying attention to, or vice versa. They'll rule you out and tell you, hey, you don't have to worry about it anymore. We've proved that this isn't a problem. And like I said, it's an evolution. So there's always new things to learn in medicine, and genetics is certainly at the forefront of that.
Amazing. Thank you. So a couple more questions. One question, which I've never heard asked before, which is why I'm doing this. If there's a family history of breast cancer and someone currently has prostate cancer, does that make them more likely to be diagnosed with a different type of cancer as well? In other words, there's already been several cancers. Does that put them at greater risk for additional cancers? I'm not talking about recurrences.
Yes, I think for most of us in oncology, we have a saying that says the biggest risk factor for cancer is already having had a cancer.
That's really
And
interesting.
so that is the unfortunate truth. And so you are at greater risk, regardless of genetics, of a mutation and developing another type of cancer, if you've already had one, no matter what it is.
Okay, thank you for that. We have just a couple minutes, so I'm going to do some quick answer questions here. So somebody asked, for those who carry BRCA mutations, is a physical prostate exam recommended in addition to PSAs?
It's not recommended, but it's not a bad idea.
Okay, we hear actually that a lot, I think, that things aren't standard of care necessarily, but not necessarily a bad idea.
Right.
Okay.
So you only feel a part of the prostate. So that's why it's not considered an adequate evaluation. But doing that in addition to everything else gets you more information. And apropos of this conversation, I did a colonoscopy on Friday and did a rectal exam before starting and found a nodule on my patient's prostate. And he's 68 years old. And when I told him about it, it turns out his father had prostate cancer at 69.
Wow.
So you always want to take opportunities where you can.
Okay. Don, somebody asked, you've had your prophylactic mastectomy, but as we know, male breast cancer isn't the only thing that BRCA mutations raise risk for. So what other kinds of screening are you doing?
That's an excellent question. I just actually was texting back and forth with Lori, who's also the BRCA2 positive, and got me into the whole male breast cancer thing. And my screening has been horrendously bad. And actually, I took a screenshot of Stuart's thing to start doing it, because it's like,
Okay.
that's the whole like one of the reasons I had a mastectomy in the first place is because they said you don't really need to do this if you're going to get like mammograms and MRI, and I'm like, clearly I'm not going to do that. So I mean, after this talk, I'm going to get enrolled to get some screening done for sure.
Amazing to hear that. I have two more questions. So one is a follow-up to what you just said, which was, we know that men often, you said it in the video yourself, we know that men often ignore their health. So I'd love all of your perspectives briefly on what can we do as a society to reduce stigma, to encourage men to seek the proper screenings for breast and other cancers from medical professionals. I think everybody might have some thoughts on this.
I mean,
So if you have
I think like things like this, and all of us in the healthcare field are spreading the word as much as we can, and the more we spread the word to everybody, the more the word gets around and realize that this is, needs to be handled and needs to be dealt with, and it's not something that's a stigma. I mean, it has to be discussed. You want to live your life and have your family be healthy. This is part of it.
anyone else have to add to that? Want to add to that?
I also think having open conversations as a family, I think most people on this call have a family unit of some sort. So normalizing speaking about health. My own father, for example, had blood in the urine for a year and didn't tell any of us. And if he had told me, a medical professional, or my mother, or anybody else, we would have caught his bladder cancer earlier. And so that is such a, maybe there was stigma to it. Maybe he thought it was no big deal. And, I often look back and wonder, what could we have all talked about for our own health, right? Maybe something I was experiencing or somebody else, so that he felt like, oh, I'm going to talk about my symptom as well, and completely normalize having these open conversations, because it may not have meant something to him to have that symptom, but it would have caught me,
Right.
and I, that would have had a light bulb go off to say, let's go get tested for some things.
You
You know,
talk about getting together at Thanksgiving with family and bringing up family history, which is a really important way when everybody is sitting around the table to share what's going on, and again, try to open those avenues of communication.
Peggy, that's exactly what I was going to say. And you know what? In some families, you can do it over pumpkin pie. In other families, you'll have to kind of sidle up to the person washing dishes after dinner and have a more private conversation. But however it gets done, you should try and get it done. It's critically important. I wish we had another hour to continue answering questions, but we don't, unfortunately. We got a lot in. There are others. Any major questions, we will try and respond. We're saving the chat box and the questions that came in earlier. So any ones that seem that they need a response and they weren't talked about already, we will do our best to do so. So as we get ready to wrap up, I want to remind you that Charcheret's amazing genetic counselors, Peggy and her colleague Rebecca Hook, consult with men, with women, families. They answer individuals' questions about their family histories, genetic mutations, personal risks, all free of charge. The Charcheret website has a section devoted to men's health and genetics, and the link to the men's health section of our website is in the chat box now. I want to thank Dr. Kreef, Peggy, Dr. Ackerman, Lillian, for your dedication to men's health and sharing with us tonight. I know you had a great impact here. I once again want to thank our sponsors for this important webinar: AstraZeneca, the Vassar Center for BRCA, Daiichi Sankyo, GSK, the Max and Anna Barron, Ben and Sarah Barron, and Milton Barron Endowment Fund of the Jewish Community Foundation of Los Angeles, and the Sigmund and Edith Blumenthal Memorial Fund. Please take a moment to fill out the brief evaluation survey that is linked in the chat box right now, the one that says SurveyMonkey on it. Tonight's evaluations will provide an opportunity to access additional resources and will impact future programming and initiatives specific to men's health. We look forward to continuing this conversation with you, keeping you up to date on new information, addressing all the diagnoses that are impacted by genetic mutations. And finally, as always, remember that Charcheret is here for you. You and your loved ones, men and women. We provide emotional support, mental health counseling, and other programs designed to help navigate you through a cancer experience before, during, and after. And all of our support is customized, confidential, and completely free. So please don't hesitate to be in touch with us if we can support you in any way, including as a previewer, someone who is at heightened risk. this is a good time to point out we actually have a Facebook group that is moderated by Peggy for anyone who lives with heightened risk, whether they've been diagnosed with cancer or not, whether they have a strong family history or a mutation. And we'll put some of that information in the follow-up email. Again, I saw that our clinical staff email went into the chat box. We'll put the SurveyMonkey, you're ahead of me, Rachel, thank you. We'll put the SurveyMonkey link in one more time. Thank you to our presenters. Thank you to all of you for joining us. And we look forward to seeing you again soon. Have a wonderful night.